2 minutes. Yes. All right. Close the door, please. Good afternoon, everyone. I'm proudly announcing our distinguished speaker today, Dr. Professor Humar Zadeh. Dr. Zadeh is a diplomat of the American Board of Periodontology and Implant Surgery. He graduated from University of California, Los Angeles, UCLA, with a BS, with a bachelor degree, followed by a Doctor of Dental Surgery, DDS, from USC Osler School of Dentistry. He completed postdoctoral clinical training in periodontology as well as a PhD degree in immunology at the University of Connecticut Health Center, School of Dental Medicine and School of Medicine, respectively. Dr. Zadeh served as a full-time faculty for 28 years, earning tenure status of the University of Southern California. He also served as the director of postdoctoral periodontology program from 2012 to 2019. Dr. Zadeh internationally recognized for his clinical and scientific expertise. He has lectured nationally and internationally in over 40 countries at prestigious conferences on topics ranging from aesthetic to minimally invasive periodontal and implant surgery, as well as tissue engineering. Dr. Zadeh has published over 100 journal articles in peer-reviewed journals, reviews, abstracts, and book chapters. Dr. Zadeh served as the president of the Western Society of Periodontology in 2017. Dr. Zadeh is an innovator of the Avista technique, recognized around the world as one of the most effective methods for the treatment of the soft tissue and bone deficiencies around the teeth and implants. He has also innovated many concepts and devices which has been patented and developed into product and clinical use in many countries. Dr. Zadeh directs the Vista Institute for Therapeutic Innovations with blended educational pedagogy on the variety of clinically relevant topics. He maintains a private practice of periodontology and implant surgery in Southern California. Please welcome Professor Zadeh.
Hello? Okay, now we are on. Thank you, Dr. Abdulaziz. Thank you, Dr. Kamal. It's a pleasure to be in your amazing country for the first time. I'm so excited to be here. I'm just so excited to see and be reunited with some of the fellows that I love and have interacted with so many years, and we have many of our alumni. I'm really happy to be here and seeing their amazing faces and seeing their successes, and I'm really, really proud to see that. I also am very impressed by what you have in Kuwait, so congratulations, and I'm really honored to be in your association and conference. So this afternoon we're going to spend a few hours together. So I know this is right after lunch. Who's ready to take a nap? I told them to keep the lights up and make the room very cold. So anybody needs a jacket, I'm willing to lend you mine. I know it's very cold, but hopefully you'll keep awake. I know that we have both dental surgeons, periodontists, and we have prosthodontists and endodontists, orthodontists, all the different disciplines. And my topic is, I know, could be more surgical. I tried to keep something for everybody, hopefully that you can at least, even if you don't do some of these things that I'm describing with bone augmentation, I think it's important for all of us to have an understanding and appreciation of what's available in terms of treatment planning and interdisciplinary interaction. So I am hoping that you can get something out of all of the some of the information that I'll describe for you. So here's a list of some of the topics we're going to discuss. It's a lengthy list. We have about 3.5 hours together. I hope you don't get too bored, but I'll try to get through as much of this as possible. We have a workshop tomorrow where we go into more in depth for those who are like to implement some of the protocols that we will discuss. As it is with any treatment that we initiate, the first step is always to do risk assessment. What would risk assessment tell us? Risk assessment will tell us the ability of our team to be able to deliver an acceptable outcome to our patient. So it's really important to know what is the likelihood of success in what we're proposing for our patient, so our patient will determine whether or not the risk and benefits will worth it to go in that path. Maybe we could select another alternative treatment. So one of the important elements of risk assessment is to realize what kind of morphology of defects we're dealing with. Patients come to us with a variety of different atrophies of the alveolar bone due to periodontitis that has caused atrophy of the bone, extractions that were maybe traumatic, perhaps accidents, or other types of surgical intervention which has left our patients with inadequate bone volume. So that's what we're going to be talking about this afternoon, is to select these patients and select an appropriate treatment for our patients based on what kind of dental defects of morphology of the alveolar bone they present with, so we can select an appropriate treatment plan for them. Not all of these patients are going to have the same results. We have a one-size-fits-all for every one of these patients. For some of these patients, we're going to really fall short. For some of these patients, we're going to overtreat. So we have to tailor our treatment to each of these patients based on the type of defect morphology present with. So if we're discussing defect morphology, it's important to have some kind of a classification of that so we can know how to proceed. So one of the best classification that I've seen is this particular classification by Khojaste, which is basically an ABC classification that's intended for determination of the risk for vertical bone augmentation. So when it comes to augmenting vertically, this classification will tell us the favorability of defects. So we have class A. Class A means that there are two vertical walls, one vertical wall on each side of the ridge that is effective. Class B is only one vertical wall on one side. On the other side, perhaps due to a tooth that has periodontitis, there's no vertical wall, or maybe the tooth is extracted and you have a flat ridge on the other side. So one wall is class B, or if there's no walls at all, if it's a flat defect, that would be considered the class C. So these classifications will tell us the favorability of us to be able to regenerate the alveolar bone. Because when we're dealing with the class A, we can basically fill that kind of a defect, and what becomes our goal is to go from peak of bone on one side to the peak of bone on the other side and fill in that kind of a defect. So that is going to give us the best outcome for vertical augmentation, have these two vertical walls. And then if you have one vertical wall, we're going to again go from peak to peak. On one side, the peak is really coronal. On the other side, there's really no peak. So we're going to have a lopsided regeneration. And there's nothing you can do to improve that if you have this kind of a defect. You're going to regenerate better on one side, which has a vertical wall, than the other. And then if you have C, you really have no ability for augmentation. So the second part of the classification has to do with the width of the alveolar bone. Okay, and that will be basically subclassification. If you have a very wide alveolar bone, you would have a class 1, subclass 1. Medium alveolar bone width will be 2, and a very narrow crest will be class 3. Imagine when you want to build one of your high-rises, right? If you have a lot of plot of land, if you have a wide base, you could really build a high-rise on that. But if you have a really, really narrow area, it's going to be very difficult on that, right? So that's why the width of the bone is going to be an important determinant, because the width will provide you with blood supply, it will provide you with the stability of the base, and it will give you a source of cell infiltration to make new bone. So the width of the bone is the second part of this classification. So then if you put it together, you're going to have the best kind of defects that are qualifying for vertical augmentation as subclass 1, class A. The second best will be class B, subclass 2. And the worst type of defect for vertical augmentation will be a class C, subclass 3. So why is this information important? Even if you're not a surgeon, if you're a prosthodontist, it's important that as you present a treatment plan to your patients, it's important to know whether or not it's feasible to do vertical augmentation, or you may have to do your prosthetic planning to use some kind of a prosthetic tissue in your restorations rather than relying on the surgeon to reconstruct vertically. So it's important for everybody to be aware of this particular classification and the feasibility of augmentation. So this is really tells you in terms of favorability of vertical augmentation, you have the most favorable to the least favorable on the other side. Then, if you're thinking about horizontal augmentation, there's really no classification of horizontal augmentation, but one of the things as clinicians we look for are concavities. When we're looking at the ridge that looks concave like this, it's a favorable ridge for horizontal augmentation, okay? Versus a ridge that is flat, okay? And you could see that why this is important, because this kind of a concavity gives you containment. If you put some kind of a graft material, it's like a bowl that will hold your graph material stable so it doesn't shift around. If you have a flat wall, it's not going to really hold the graph material, and the graft is going to shift around. So in terms of horizontal augmentation, you could see that the concave type of defects will give you better outcome than the flat defects the way they are. So when we're looking at some examples, here's an example of a flat defect, right? So if you just put particulate bone on top of it, it's not going to work so well. You need some kind of a device to stabilize that graft material. But if you have a concave defect, you can just fill in this kind of a concavity, and that's going to give you stability. So you want to look at these things beforehand, and you know what you're in for if you're going to an easy case or it's going to take more effort and you need to use more tricks to be able to augment. The next thing that we need to decide is the material selection. We have to decide what kind of materials we're going to select, because the choice of material is going to dictate our favorability in terms of outcome. So when it comes to material selection, we have different scaffolds. These are bone substitutes. These are just basically powdered bone substitutes that we can purchase in a vial. It could be either an allograft that may come from another human being. It could be a xenograft that could come from an animal, or it could be an alloplastic that are synthetic. So all of these are options that we can choose, and much of it falls onto preference. But there are some nuances about these. The next thing is using autogenous bone. We can take bone from the patient. But autogenous bone, taking bone from the patient is not all the same. You can take a block of bone from the jaw, from the posterior mandible or the chin. You can take that block and grind it up and make it into particulate bone. Or there are some rotary devices that you can basically drill into the bone and collect some kind of a particulate bone. So these are all different ways that we can collect bone. Or we can use a scraper. And they're not all the same. We'll explain that the efficiency of these kind of bones are very different. And then we have different choices of membranes we could use. We can use the resorbable membranes, primarily collagen membranes. The collagen could be also different kinds of collagen. You can have some synthetic PTFE membrane. These are like Teflon membranes. And we have titanium mesh as another form of membrane. The kind of response that we get biologically from these membranes is very different. So our choice could really dictate what kind of complication rate we're going to encounter and how successful we'll be. Next is that we need to fixate our graft material and our membranes. We have a choice of different kind of screws and pins and other devices that we can use to fixate our membranes and bone. And then we're using increasingly biologics. I know Dr. Kamal is going to be talking about PRF, so I'm not going to go too much into PRF because he's going to cover that topic. We also have some synthetic growth factors, and these growth factors are not available everywhere, but these are kind of proof of principles of how it will work. So we have a lot of choices. As clinician, it's always good to have many bag of tricks that you may use at different times. So I wouldn't say I would only use one thing and nothing else, because it's always good to have more options rather than less. So then we discuss the choice of membranes, right? Do we need to use a membrane? You know, membranes are expensive. Maybe we can skip the membrane or use different kind of membrane. Well, this is a study that basically looked at that and said, what if we use a membrane, one of those Teflon membranes, or maybe we use an open format kind of a mesh, that's a custom mesh that's created. Both of them are creating the same amount of space. One is closed like a membrane, barrier. The other one is open. And the idea is that if you have open channels, it's going to allow the periosteum to contact the bone and provide circulation. The one that is completely a barrier, which is a Teflon or PTFE membrane, is going to separate the periosteum, soft tissues, from the bone. And the question was, would there be a difference? So this was a study done in monkeys. And what they found is that there was slightly better amount of vital bone when they used a membrane than open format, but the difference was so small that it's not really clinically relevant. 77% bone versus 68% bone. They're both essentially similar. So what this means is that it doesn't matter if you use a barrier or you have something that is giving you this kind of a mesh device, they both work. And the reason is that the most important concept in bone augmentation is space maintenance. This is true anytime you want to make any kind of regeneration, whether it's soft tissue regeneration, bone regeneration, you have to create a protected space. You have to create a space that is protected and is surrounded by that kind of tissue, by bone tissue. If you protect that space, you're going to form bone in there. So that is the concept of a protected space, and that's what we're going to create if we're trying to regenerate bone or soft tissues. So there's also animal studies in dogs to look at this concept of if the membrane makes a difference or not. They use the collagen membrane, they use the bovine bone, or they use collagen membrane plus bovine bone to see if there are differences. And what they found is that when they used the collagen membrane by itself, they got the best quality of bone because there was no particles of bone in there. Because if you have particles of bone, you're not going to have as much of that. It's just like if you order soda, if they give you half of that glass in ice, you're going to have less soda in there, right? So it's the same concept. If you fill up a space partly with particulate bone substitute, part of it is going to be occupied by that bone substitute, so you're going to have less of the bone, but it really doesn't matter. But the difference is that the volume of bone was not so much because there wasn't anything to protect that. If they had just the bovine bone by itself, it had a good volume, but what was the problem is that some of the soft tissue had grown into it, so it wasn't being contained. They found the best results when they used the particulate bovine bone in conjunction with a collagen membrane, because they maintained the space, they gave them the volume, but they didn't have the tissue growing into that. And this has been studied over and over, that you see the best results when you use a combination of a particulate kind of a bone substitute, and this bovine bone, along with a membrane, gives you the best results. So I know some of the colleagues today, they don't want to always use a membrane because membranes are expensive. They say, well, maybe we can get away with it. But the reality is that membrane does add some value in there. Now, there are so many different kind of membranes. Is it going to make a difference what kind of membranes you select? You can use collagen membranes. You can use PTFE, which is like a Teflon membrane. You can use a titanium mesh that's like neatly woven or open format. Or you can use PRF as a membrane. So these are all different choices of membranes we have. And it's important as a clinician, and if you go to the hall next door, you'll find they're selling you many different kind of membranes. You can find all of these in the next hall. So which one are you going to purchase? Which one are you going to use for your patient? Well, we can go based on our experience. We can go take a course and they tell us what they're using. But the best way to find out is what the studies are showing. And the studies compare the PTFE membrane, that is a Teflon or Gore-Tex membrane, and compare that to the collagen membrane with the titanium mesh. The titanium mesh or Teflon PTFE membrane, they found the important difference was the percentage of complication that they encountered. With the titanium reinforced PTFE membrane, that's the Gore-Tex membrane with titanium reinforcement, they had 45% complication rate. With the titanium mesh that was covered by collagen, they found 36% complication rate. How many of you like to have 45% complication in your practice? Raise your hand. How many of you would like to have 36%? Like 1 out of 3 patients is going to be a complication. The reality is that there are a lot of people putting up courses and teaching people how to use both of these kind of devices. So if you're looking for complication, you don't mind every other patient is going to be going back to clear complication, by all means go ahead and use it. The results are great. When these materials work, they work great. But the problem is complication. I like to take care of one patient and go on to the next and don't go back to the same patient and take care of the complication. That's just me. I don't want to deal with that. So the reality is this, and I can tell you that many of the top-level clinicians are teaching these kind of materials, and for me, that's a problem because I know people who've taken those courses and they, email me and say, look at what complications I have. Now, this is, when you look at the studies, some of the studies say there's no complications at all in the grafting, right? 17 studies said when they looked at their results, they had no complication. When someone tells you, I have no complication, what do you think? You say, well, maybe either you're not doing enough cases or you're not being very honest, right? Or you're not looking. You don't want to know. So the most common complication is wound dehiscence, graft exposure, the flap opening up, exposing the membrane and the graft. That is the most common complication. And it could range anywhere from 5 to 54%. That's a wide range, right? From 5% to 54%. I want to know what those people are doing that are getting 5% complication, and whatever those people are getting 54% complication, I want to do the opposite, right? So that's the thing that we look at these studies to find out what types of protocols are working, what protocols are not working, so we can base on our protocol, our philosophies, on the types of protocols that have better results and less complication. Infection is not so common. We have a relatively low rate of post-op infection, 7 to 13%. So I mentioned to you that complication from membrane exposure, especially the titanium reinforced or PTFE membranes, the Teflon membranes. It used to be Gore-Tex before. That was the brand. It's no longer on the market, but there are other PTFE membranes that are on the market today. They're great when they work, but the reality is that there are complications. And here's a publication that tells you different classification of complications based on the location and the type of complication. When I see that, I say, you know what? I don't need any of this, right? Because it's really not necessary to use the types of membranes that are leading to these kind of complications. I use them. All right? So these are some of the cases that they published with this kind of exposure of the membranes and complication. How many of you have seen this kind of complications with PTFE membranes? Raise your hand. Anybody who uses this membrane will see that, right? It's just the nature of it. Okay, these are different complications, and this is something very common that you see. And those people who are more honest, they tell you this is very common when you use this kind of material. This is one of my cases, right? Look at that. Not a good day in the office, right? I don't want to see that. So occasionally, I listen to colleagues and I see, well, it looks so great, the results using this PTFE membrane. Maybe I wasn't doing it right. Maybe I try it again. This is what you see. So, you walk into the operator, you can smell it, right? You say, I just don't need that. So that's one of the criteria that I will describe. The kind of protocols that I provide you today are ones that have far less of these kind of complications. I would never tell you there's not going to be a complication. Anything you take on, you are going to deal with complication, and you should be prepared. But if you know right in the beginning, based on your choice of material, you're going to have complication, you want to basically know that. You want to avoid it. So here's a list of different kinds of membranes and the percentage of exposure. And you can look at this list and see that it's a wide range, right? And look at this list and say, what's the least exposure rate? 16%, native collagen. That's what I want to use, right? Because if that's the lowest exposure rate, that's exactly what I want to use. Why should I use one that has higher exposure rate? The good thing also with collagen is that when it gets exposed, it's self-limiting. I would just assure the patient, you're going to be fine, come back and see me in a couple of weeks. Maybe you can swab it with some antiseptic, make the patient feel better, but it's going to resolve itself. I don't need to take out the membrane, I don't need to deal with it, right? So that's why I will basically favor this type of material that has lower exposure and complication rate. So then it comes to the flap design. So we're going to deal with different areas. And I can tell you that when we are dealing with regenerative techniques, one of the most important aspects has to do with flap management. So those of you who are not doing this in your practice, bear with me because I think there's some information in there. Even if you're not doing this kind of augmentation, it will be beneficial to see how the procedures are done. So when you're dealing with deciding about bone augmentation and what kind of flap design you have to select, there are three different considerations. The first consideration is about vestibular depth. Do you have a shallow vestibule or you have a deep vestibule? Obviously, if you have a deep vestibule, you can pull your flap and fit your graft material underneath there, right? It means like if you have a very shallow pocket, you can put very few things in there. If you have a deep pocket, you can put more stuff in it, right? So you want to have a deeper vestibule, will give you more ability to have bigger flap to contain more graft material. Next is the condition of the periosteum. If your periosteum is healthy, the flap is healthy, nobody's messed with it before, you're going to have better results. But often, we get a patient who's had an implant that has failed after the tooth was extracted and grafted, then they grafted again, and then the graft failed, and then they did another graft, and by the time you're done, there's so much scar tissue, the periosteum is so scarred that the blood supply is really compromised. So you're going to treat a patient who has very healthy periosteum and healthy flap, good circulation, differently than one that has a lot of scar tissue and has really quite a bit of scarring. Then the next consideration is that what kind of membrane and graft material we're using. Obviously, if you're using certain kind of membranes, it's more critical that you keep everything contained. Other kind of membranes, you can perhaps have a little bit more leeway there. So depending on what type of graft material and membrane you're using, you can have different flap design. So let's take on a very common problem that we have, edentulous posterior mandible, right? In the posterior mandible, we often have that, perhaps that's the most common scenario we deal with, right? Patients had mandibular molars or mandibular molars and premolars extracted. Now they want to place an implant. You have the alveolar, inferior alveolar nerve, so you need to do some augmentation there. So that's a very common situation. So let's look at this area, and you can see this is the anatomy of the mandible. If you don't remember, the mandible, the floor of the mouth is lined by the muscle, which is mylohyoid muscle. So when we are planning our flap, we need to know that information. So here's the situation of a patient who's been edentulous, has been wearing a partial denture for decades, for 35 plus years. Now she has a little bit more money and she wants to have implants there. She doesn't want to deal with a partial anymore. And this is a very common scenario where we have natural teeth that are healthy, have a healthy periodontium in bone and attachment, and then an edentulous area that is quite atrophic. This is very common. And you see this pattern of topography of the bone. So when we look at that, let me ask you, is it class A, class B, or class C? See if you were paying attention. Class A, how many of you say A? How many say B? How many of you are sleeping? Raise your hand. Okay, yeah. This would be considered B because you have one good vertical wall anteriorly. So we have the ability to build up the bone better near this area. So that is a consideration. And again, even if you're not doing the surgery, you're a general practitioner, restorative dentist, you still need to know this information and say, before you make a referral to a surgeon, what would be the likelihood of augmenting this bone? Posterior mandible, actually bone augmentation works really well if we follow the right protocol, because we really don't have any other choices. You see, we only have about 2 millimeters of bone superior to the inferior alveolar nerve, so we can't use short implants. We don't really have any other options. Now, we have all these clinics in the US that specialize in all-on-4. I'm sure you have them here too, right? So if this patient ends up in one of those clinics, believe me, they're going to extract those perfectly good, healthy, natural teeth in the anterior just because they want to make it easier to do everything in one session. And it's really a shame, or I would say a crime today, that we see that very often, because we can reconstruct this successfully. The consideration is that if we're building that up, the anterior wall will give you a very nice support. The posterior have to do something else to give support to the graft material that we're using. So now we're looking at this area, and you see the patient has very thin tissue. Is it going to be a problem if we are dealing with a very thin tissue, no keratinized tissue? I know many colleagues, when they see this, they say, well, this looks like a problem. Maybe I should do a free gingival graft to augment the tissue first, and then do our grafting, bone augmentation. I would advise you against that. even though it may make intuitive sense and say, I can make better quality of tissue with a free gingival graft, make a lot of keratinized tissue thicker, maybe we'll have less exposure of our graft. The problem is that when you're doing that kind of a procedure, it's going to create that scar tissue that we were talking about. Your flap will be now scarred, and it will be much more difficult to manipulate it. So you don't need to do that. You do need to do a soft tissue graft in most of these cases, and I'll talk about that, but you don't need to do it before, because if you do it before, it's going to make your bone augmentation just more challenging. So we have very little keratinized tissue, no problem. We make our incision right in the center of that, okay? And as long as you stay right at the crest, you will have good blood. You just have to make sure very carefully do the flap, and you reflect the flap. Usually in the posterior mandible, when you reflect your flap, you're going to see this guy here, the mental foramen, and the neurovascular bundle that comes out of it. You just have to be careful so you don't do sharp dissection down there. So then we're going to harvest a bone graft. This happens to be a block bone graft because it was convenient. It's right there. It's a great source of autogenous bone. And because we had this class B defect, right? On the anterior side, we had a really favorable vertical wall. Posterior, it was flat. So we need to do something to boost that. So adding autogenous bone really helps. So we just take a block of bone, we grind it up, and we can make a combination of 50-50 of autogenous bone, in this case with bovine bone graft material, mix them together, okay? And you can create the bone. Now, today, if I were doing it, I would listen to Dr. Kamal and I would do the sticky bone, right? That's what we are doing today. We're making sticky bone. This is a little older case. I wasn't using that, so I was using just the blood from the local area to create a, not so effective sticky bone. But then, you see, you have this particulate graft, and you have one slope, right? The slope, the wall on the anterior side is going to give you stability, but you don't have anything in the back to give you stability. So you're going to give that stability from using these tenting screws. The tenting screws, we're going to place them into the bone, and kind of like if you want to build a tent, you're going to put these tent poles, and it's going to stabilize. You're going to use the same kind of a concept to create these tent pole effects. And that's going to give stability to that particulate bone, so it's not going to shift around. So we would install a few of those in this area, some of them for vertical augmentation, some of them for horizontal augmentation. Just like if you want to build a tent, you're going to put tent poles in the shape of the tent that you want to create. So you put these tent poles to support the membrane that goes over that to create the right kind of a contour of the ridge that you want to create. So this becomes skeleton for the bone graft that you want to create. Now we're going to make our flap mobilize. We need to lengthen our flap. Remember, our vestibule was really, really shallow, right? Because the ridge was almost at the floor of the mouth, way down there. So we don't have enough space there. To lengthen it, what prevents the movement is the periosteum. So we need to cut the periosteum there, and that periosteum releasing incision is going to mobilize the flap on the buccal side and give us the mobility that we need. The only thing is that because you have the mental foramen with the neurovascular bundle coming out of that, you want to make sure that when we're making our incision, we're not cutting branches of the neurovascular bundle, so we go around the nerve in this way. But if you keep the incision very superficial, you're going to not cause trauma. Now, I have to say, today, I've changed this protocol. I try not to use this periodicity releasing. We'll use some maneuvers, and I will show in the workshop tomorrow how we do these maneuvers that we can actually avoid these kind of incisions. We can actually stretch the flap very effectively without making this kind of an incision, because any incision we make is going to compromise the blood supply. So we're going to keep the blood supply intact. Now we're going to go ahead and stretch the flap a little bit. So you see, this is the base of the flap, and we stretched it. So now one side of the incision is here. We stretched it down to here, so now our flap is longer. Because when you look at it, you see this is a periosteum, this is periosteum, this is a submucosa that's exposed from stretching the flap underneath, right? So then you have the mental nerve, the neurovascular bundle that we try to protect during our manipulation. So the most important thing in flap management in the posterior mandible is release of the lingual flap. Because on the buccal side, we have to do this kind of a releasing incision. Today, we can actually do that stretching without the release. But on the lingual side, we can actually get quite a bit of release. Because what is preventing the release there, the movement of the flap, is the attachment of the flap to that mylohyoid muscle. So you see, all we have to do is to use a kind of a blunt instrument and push against our flap, and it's to mobilize the lingual flap to the point that we will fit a lot more material underneath it. So you see that we think we were able to mobilize the flap quite a bit in this way. Now you see you have the mylohyoid muscle. So that's why there's so many vital structures. You have the lingual nerve, you have the submandibular duct. You have to be very careful on the lingual side that you don't use any sharp dissection. You don't use any kind of a blade there. You just use that teasing force just to push the flap away, and that releases the lingual flap and gives you much more mobility to contain your graft material. Okay? So then you're going to use a kind of a suturing called internal mattress suturing to kind of reposition the flap and keep it, get primary coverage. And this allows you to do kind of a 2 layers of suturing in a way to avoid the graft exposure. So if you use this kind of suturing, you can see the steps in passing the sutures. Again, something we'll show in the workshop tomorrow. You use this internal mattress suture, and you can pull the base of your flap together, and that way you're mobilizing your flap, and in a way that it brings the flap together with as little compromise of the blood supply. Because the internal mattress sutures are put in very deep, they're not going to compromise the blood supply. Then we put our particulate bone, and you see those tent poles are really kind of supporting our particulate bone so the bone doesn't shift around. And then we'll put the collagen membrane, and then we have to stabilize the collagen membrane underneath, and that keeps everything together. So you see I put the sutures in first, so that way when it comes to it, once you put the membrane, you tack it down, you just pull the sutures, and it gives nice approximation of the flap. We just didn't photograph it, but you see when you put your internal mattress sutures, you're going to bring your tissue up together, connective tissue against connective tissue, and you see the margins of the flap are coming together up, everted up, and that way there's no possibility of exposure of the material, because now you have the flap against flap, and that's going to give you much more secure approximation of the flap. So this is really the key. And then the second key is that you use very, very small gauge sutures and the crest, because when you make a crestal incision, you're going to compromise the blood supply, so you don't want too much tension there. So when you use this kind of a situation, you're going to have much less chance of wound dehiscence, flap opening up and exposing the membrane or the graft material. But the biggest chance here is exposure of those tenting screws. The tenting screws can become exposed. And I purposefully kept a case like this where the screws became exposed to show you that when those screws become exposed, it's not a big deal. These are just titanium screws. Just like a titanium implant going transmucosally, it will have no problem. So the titanium screws can get exposed. Most of the time, you leave it alone until the time that you're ready to place the implant. At that time, you can remove it. But most of the time, you don't need to touch these screws until the time that you're ready to remove it. So this is after 1 month. By 6 months, you could see that 3 of those screws became exposed, and you see it's really inconsequential. So we waited, in this case, 8 months before placing the implants. And when you take your CBCT before and after, you see good volume, especially in areas that had those tenting screws. So you see the ridge crest was really, really narrow before, and the ridge is much, much wider below. But a lot of times, the CT scan doesn't really do it justice. And when you look at the CT scan, it underrepresents. When you open the flap, now you get to see that the bone is really vascular. It's really hard bone here. Feels pretty strong, right? It's very hard bone. Trust me, anyone who wants to come up and test it, you can. It's solid. So that's the thing. When you see this kind of a blood supply in it, it's just vital bone, right? So that is the key to building that vital bone, is make sure you have the right support, you have the right material, and you avoid complications that could compromise the result. Now we're going to go from there to here. You can see that we brought the base of the ridge that was way below to the same level as the bone on the natural teeth. And that's the key. A lot of times you have the natural tooth, the bone in one level, and the alveolar bone of the edentulous area in a slope. Just like you don't never want to build a house on a slope, you don't want to put an implant in a slope. You want to flatten the ridge by building it up, and that way you can place the implants that are at the same level as the natural teeth adjacent areas. So now we're going to place these short implants. You don't have to put long implants. Remember, we only had 2 millimeters of bone above the nerve, and we built enough bone to be able to place 6 millimeter long implant. Short implants work just as well as longer ones, okay? But we placed 3 of them, and when we place the implants, now is the time to do your soft tissue management. You have to use a soft tissue graft in every one of these cases. It's just that you don't want to do it before, you want to do it at the time of implant placement, because that reduces the number of times that you have to do an intervention on the patient. So you would do basically this kind of a tissue augmentation. This happens to be my favorite tissue, which comes from the tuberosity. The tuberosity is much less invasive. You can harvest the tuberosity with very little ease, discomfort to the patient, and it gives you good quality of tissue that actually has much less shrinkage than palatal tissue and less morbidity. Now you see, we place those short implants, and this is something for our restorative doctors that I prefer to keep these not splinted, individual. Now, I know some people will feel more secure when they're using short implants to splint them together. Actually, you know, these implants have the ability to have some flexibility in the bone if you don't splint them. And we find that the bone response to these non-splinted short implant is excellent. So you give, you know, the natural ability to have a little bit of adjustment in the bone by flexure. This is another situation. So this is a little bit newer case. I think this happens to be my brother. So you see atrophic posterior mandible, and we're going to treat his case. We have many of these courses at our institute in LA, and we always give live surgery demonstrations. So, you know, when you can't find a patient, you always go to your family members, right? So here you see very thin bone. We're going to make a crestal incision. You reflect the flap. You see there was an implant back there because we had an implant there in the posterior side. When we extracted the other teeth, we allowed that to become submerged. And you see releasing the lingual flap. All you have to do is to push the flap away, and it's going to, you're going to see, you could see the fibers of the mylohyoid. This is the key. You want to see the fibers of mylohyoid. Can you see that? Right there, those are the fibers of mylohyoid. When you see that, that means that the flap is released enough. Now you can basically mobilize that lingual flap. Now we have some biologics. This happens to be a recombinant platelet-derived growth factor. We find that to be useful. I know you don't have access to it here. Actually, Geistlich just bought this company that makes their growth factor. Maybe they will introduce it in other parts of the world. But if you don't have it, maybe you can just use more autogenous bone. Here, you see that I made the sticky bone. The sticky bone is a combination of the PRF, the liquid PRF, the solid matrix PRF, autogenous bone, and particulate bone substitute. So we mix all of that. It improves the handling of the graft material, but also it keeps it more like a solid, like a putty style. So that way, there's less chance of micromotion of the graft material. So it solidifies that particulate bone. So now we're going to install these screws. These are special screws called ModFix. They're modular, so I will show you more about them. You see that they don't have a head. They're different than what I showed you. These are ones that we designed because what happens now, we're going to puncture our collagen membrane. You see, it's a very soft collagen. We don't need to use a PTFE or one of those stiff membranes because those stiff membranes obstruct the blood supply. This is much more biologic. You see, these screws have two pieces. One piece is the screw itself. The other is the abutment, which basically does two things. It does both the tenting as well as membrane fixation. So it makes it much, much easier. So we put the particulate bone underneath it, and we put layers of PRF on top of it. And the reason we put the PRF on the surface is because, as I will describe to you later, PRF doesn't really cause bone formation. I don't put it there because I think it's going to cause more bone formation. We don't have enough evidence. But it will improve the patient experience. It will reduce the pain, reduce the swelling, reduce the chance of bruising, and also improve the blood circulation, and maybe make it less likely for the flap to get exposed. So these are all good reasons to put several layers of PRF right under the flap as a security policy. So you see now we use the internal mattress suture, and the internal mattress suture brings the flap together with as little tension as possible. You see, we put these very deep internal mattress suture. By the time we're done with that, the margin of the flap are everted, and they're right next to each other. So we have to do very little effort to close the margin. You see, we stuff more of that PRF right under the flap. It doesn't matter where we put it, because that PRF is like a slow release drug delivery system. It's releasing the growth factors underneath the flap to improve the outcome. So you see, when we put this in this way, we don't have to put a lot of tension. Even though the tissue has no keratinized tissue, the mucosa is very thin, it's still easy to manage it in this way. And you see, after the augmentation, we get a large volume of bone. We brought the base of the bone that was much more atrophic and lower. We bring it at the same level as that of adjacent teeth. Now we go back, and you see, we make our incision. Now we're going to remove that was a membrane fixation screw. Those are the tenting screws that we place. You see, we have good quality bone. We're going to perform our osteotomy using our guide, and you see, we take a block of bone with a fine because we do histology. And we don't have time to show the histology, but you see, those are solid blocks of bone that we harvest out of the area, showing you that this is really good quality bone that's created. And now, when we place our implants, we put PRF around it. I will show you this technique of vestibular extension, PRF. Okay? This is the technique we call 5. I will show you more about this technique for vestibular extension. So we are using that as an alternative to taking gingival graft from the patient. So we have different techniques. Let's see, all of us have preferred techniques. If I go around and survey all the surgeons here, everybody has different preferences for technique, and that's okay, right? But on some hand, we have to compare these and know if there's any kind of evidence-based data that we have to show one technique works better than other, right? If we select techniques that have better results in studies, then perhaps we can use those and be more successful. So we can look at the different techniques. This is called the tent pole techniques that I showed you. We use the tenting screws, and then that's called the tent pole technique. You can see that putting particulate bone around it, collagen membrane, and then covering it. I wouldn't advise you to use this kind of a flap design. I think this is not a good flap design. You don't want to put the flap so tiny right near the graft material. It's a bad idea. The bigger flaps actually are what we call safety flaps. You have better blood supply. The closer the margin, it's not less invasive, it actually compromises blood supply more. Nonetheless, this is the technique that they did in this study. It was a randomized study comparing it to the PTFE. These are the Teflon membranes, the PTFE membranes. Okay, these are synthetic and they're textured. And comparing to the tunneling technique, vestibular tunneling. Basically making an incision in the vestibule and putting the particulate bone in there. I will show you the vestibular approach for grafting later this afternoon. But their study compares these 3 techniques to look at their outcomes. Now, when you look at membrane exposure, look at that. Tenting screw, 11% membrane exposure. And, it wasn't even the best flap design. But you see, 11% is where, look at open PTFE, 52% exposure rate. So this is a side-to-side comparison of PTFE to tenting, tent pole technique. So that's why, I selected, not because I love tent pole techniques and that's my personal bias. Of course it is. That's what I have a lot of experience doing. But the studies have supported side by side that the tent pole technique has much less complication rate. 11% exposure to 52% for PTFE. And also, the tunneling technique is also very good. The tunneling technique only had 19% exposure. But then, when we look at implant placement, the tent pole technique, 97% of the time, almost all of them, they were able to place the implant. But the PTFE technique, only 71%, they were able to place the implant. That means for almost 1/3 of them, they had to go back and do more graft to be able to place the implant. So more exposure and less success. So I really can't emphasize the poor choice that this particular protocol is. And then when we look at the tunneling, 86%, somewhere in between in terms of the outcome. Now, the tunneling technique that they use, they just made the vestibular incision and just inserted particulate bone. I will show you the technique that combines the tent pole techniques and the vestibular approach, because if you just inject in particulate bone, it's not going to give you the stability that you need. So I will show you more better result. So there's several papers on the tent pole techniques, and we'll describe more of them. So now that we discussed talk about the maxilla. The maxilla is different because the maxilla, you have the palate. The mandible, you can mobilize the buccal flap, you can mobilize the palate, the lingual flap, and you can really fit a lot of material underneath. With the maxilla, you can only mobilize the buccal flap. The palate is stationary. You can't, mobilize it, right? So what you can do, you can kind of do a split dissection of the palate. You can split it into half, and that way you can basically mobilize the flap on the palatal, and I'll show you how we do that. Now let's look at another little trick that we could use. Now we have this classification, A, B, C. But do you have to accept whatever the patient gives you? If the patient comes with something less than a class A, can you improve there and make it more favorable? Well, one of those situations is that if you have class A, you have those walls, you're going to have really good bone augmentation possibility. But with class B, you're really limited on one side. On one side where you have the vertical wall, on the other side, you really don't have the ability to vertical augmentation. So what can you do here to improve that? What do you think? What can you do on the side of the defect? Perfect. Dr. Albazan has just the right answers. Thank you. So that's correct. You see, you can use orthodontic extrusion. That's perfect. Or if the patient doesn't want to do ortho, you see that with ortho, you can actually bring that peak of bone more coronal. Or you can do extraction, and that does the same thing by moving the peak of bone to the next tooth, which has intact bone. So now let's see a case and see if we can implement. So again, even for the non-surgeons, this is something, as you treat, perhaps you can think about alternatives to know how you can treatment plan the patient in such way to make your case more favorable. So you can see that we converted the case of a patient with class B to a class A by the decisions that we make, either orthodontic extrusion or extraction. So here's an example of a case right here. What classification is that? A, B, or C? Kind of a B to a C, right? Because coronally, there's a lot of vertical loss here, so it's almost like a C. You know, on one side you have wall, so it's like a part of it is a B, part of it is C, but it's really mostly, I would say, B is the most descriptive. So what kind of a bone augmentation can you do there vertically? Peak to peak, right? That vertical, that the periodontal attachment loss on the lateral incisor will make it less likely to do augmentation on the anterior side. So you can see that the amount of vertical augmentation is going to be limited, right? So can you do something else? Well, we proposed ortho to the patient, and she said no. So we went ahead and planned for extraction. And you can see when you extract, instead of that pica bone being up here, now the pica bone is the distal of the central incisor, which is an intact periodontium. So now you can have this much bone augmentation. So just by one decision, you can improve your ability to be more effective in bone augmentation. So it comes down to treatment planning rather than surgical skill. So you see, you had a class B. Now you are able to convert that patient to a class A, right? So that is making it more efficient. Yes? How about if I finish this case and then we take a break? That way yeah. So I'll finish it up and we'll take a break. Everybody seems awake. I'm impressed. Good job. I was expecting a few people nodding after lunch, so very good. So you see, we split the palatal flap. That way, we're lengthening our flap. You can see that we reflected it. You can really see you have a vertical wall on the posterior side, but you see there was no vertical wall. By that extraction, we brought the pica bone much, much lower. So you made it for a much more efficient and more favorable defect. That was class B. Now we made it class A because we brought the pica bone level to give ourselves better ability to augment. Now we're going to, you see that before we could only augment that much. Now we can augment far more, right? Not just because of our technical skills, because of our treatment planning skills. So now we're going to put these tenting screws. Maybe in this case I got a little carried away. I fell in love with these screws, but this is just the way. You see, we place the tenting screws to support the buccal, the crestal, and palatal. Because most of these cases also have palatal atrophy, buccal atrophy. So if you want to build a tent pole, you want to support buccal, palatal, and crestal. So now we're doing our periosteal releasing. We're mobilizing our buccal flap. Now we can fit a lot more material. And you see that we use our tenting, your mobilization. We attach the collagen membrane. You see, it's a very pliable membrane. The membrane by itself is not stiff. We don't rely on stability of the membrane because the membrane is more biological. We rely on those tenting screws to support our graft material. So then we put our graft material, drape over the membrane, stabilize the membrane, tack it down, and you see, use the internal mattress suture. And you see, we are basically have approximation of the flap. So the very important point is when you have this kind of augmentation, provisionalization is as important. Never use mucosa support prosthesis. You never want to use a removable appliance. Most colleagues, I would say, use a removable appliance for these patients. If you are, it should be a tooth supported. Like this one here, like a Essex appliance or Invisalign style appliance that is tooth supported even though it's removable. Okay? You see now we were able to open the area and here's what we have. And another important point is that when you're planning for implant position, it's always better not to have an implant right next to the adjacent natural tooth. If you have a pontic here, and that's what we have, typically next to the adjacent to the natural tooth, we rather have a pontic because it's much easier to manage the contour of the tissues with a pontic there rather than implant. So step back the implant a little bit further, so you would have an implant underneath the canine and the lateral incisor is restored with a pontic. So this is usually very helpful for the tissue management. All right, so let's take a break. So, Mr. Chairman, how long? 15 minutes. 15 minutes. Don't go away. Okay, I'll be here just in case someone has questions. I'll be happy.
Test, hello, check. Test, hello, check. Test 1, 2. Check, hello. Check, hello, check.
So we're going to start in a minute.
I think they're having too much fun outside.
It is fun outside. I'm
When
gonna
they
go get
see
them.
colleagues, it's nice to see everyone, friends, right?
Thank you. Very informative. lecture, but we will save the questions for later in private. If anyone has any questions, we'll keep them for later. Thank you.
Yeah, smoking is a big problem. Yeah, just have to inform them that there's higher chance of complications. Yeah, I think especially there's a lot of people who smoke shisha here, right? They could sit for hours, right? Smoke, so that does affect adversely the flap. So the possibility of graft exposure is much worse. So when you're treatment planning, just know that you're going to have less chance of success, more chance of graft exposure. Maybe we don't overfill those grafts so much. We have to really be careful of how we manage the flap so we don't have compromise of the blood supply.
Okay, Dr. Zada, we will start in a couple of minutes. So I would like to thank you for the first portion, for giving the first portion of your lecture. I want to remind the audience that tomorrow we're going to have a 4-hour hands-on workshop given by Dr. Zadeh. The topic of the workshop will be 3D alveolar ridge augmentation workshop. It will be all hands-on, and he's going to go over his tips and techniques and how to handle different kind of defects and how to perform the various techniques of bone grafting. There are still a couple of spaces limited spaces available for the workshop. So if anybody's interested, you can go to the registration office or the desk in the front, and you can sign up for it. Okay.
Thank you, Professor Kamal. So this is a very complicated case where the patient had an implant placed and the implant failed. They did a graft and placed another implant. That one failed, and they extracted 2 teeth now, the lateral and the central. And finally, the patient got fed up and said, you know, I'm going to find somebody else to do the work. And you could see by the time she came to see me, she had severe atrophy. She had this bridge, the provisional bridge made between the canine and the left central incisor, so 4-unit provisional FPD to replace the 2 missing teeth, central lateral. So you can see that there's significant vertical deficiency, and there's also attachment loss on both the left central as well as the canine. So what class is that, A, B, or C? Most of these tend to be combination, right? Not one thing. In the apical part, there's a short vertical on the anterior, very, very short vertical, almost no wall anteriorly. So maybe it's more like a B. And then because there's attachment loss on both of these teeth, and you can see it's manifested in the recession on the canine. So both, there are 2 teeth that are periodontally compromised. Posteriorly the canine, anteriorly the left incisor. So what to do? What do you think? In this case. If you do augmentation here, you can see that this is what you have. Primarily a B, kind of a classification, right? So the augmentation will have limited success. Is that correct? You would have that limited success. So when I was planning this case, I consulted with many colleagues because I wanted to see what everybody's opinion was. I consulted with other periodontists, oral surgeons, orthodontists, prosthodontists, and just get everybody's idea to see how we're going to manage this patient. So one of the ideas was to use orthodontic extrusion, right? If you use orthodontic extrusion, you can maybe convert that patient from a class B to a class A, right? So that's a good way to bring that pica bone more coronally. So you would have to just cut down these teeth, the canine and the incisor, as you're erupting them. But still, central laterals are big problem in terms of the reconstruction, because if you place the implants, you're going to have an issue. So you see the peaks of bone that are elevated, you're going to have better bone because of the forced eruption. But if you place the implant there, the bone in between, you will really not have a papilla when you have two adjacent implants. So that still is going to be challenging in terms of the aesthetic outcome, right? So what else can we do to overcome that? One of the options was to actually translate the tooth, bodily move it anteriorly. If we bodily move that canine anteriorly into the position of the lateral incisor, what we're going to do, instead of a two-tooth defect, we create a one-tooth defect. So you see that as you bring that canine anteriorly, it leaves behind a good trail of bone, so we don't need to do any bone augmentation, typically where the canine was removed. And then in the edentulous area, we have a single tooth defect. Now we're going to have a more effective bone augmentation, and now the implant that goes there is going to have a little bit better aesthetics. Because if you have multiple adjacent implants, the papilla is dictated by what? The bone on the implant will dictate the position of the papilla. But if you have a single implant and you have adjacent teeth, the papilla is dictated by what? Periodontal attachment of the adjacent teeth. So you're going to have a much better papilla if you have a natural tooth than if you have two adjacent teeth. So again, these come down to treatment planning. By treatment planning and using some creative, adjustments, we can improve our outcomes and maybe have better outcome. So this is what we ended up doing. We use orthodontic movements to move the canine into the lateral incisor position and have the space that was made for the canine be able to place an implant there. Now, I have to tell you, I don't know how it is here, but I usually seek out some really good orthodontists. I've worked really top-level orthodontist. The orthodontist in this case was an excellent orthodontist, but I have problem because in this case I had a lot of discussion with the orthodontist how we're going to implement it. Any orthodontists here? No orthodontist? Okay, we can talk crap about. I'm just kidding. No, just kidding. No, so by this movement, we decided we're going to install these TADs, these temporary anchorage devices, these mini screws, and the orthodontist was going to use them as anchorage to be more efficient in translating the canine into the incisor position. So we agreed on that. He told me where he would like those TADs, and then I see the patient time after time, he's not even using them. He's, using the coil spring system, which is fine. I mean, that's what he's comfortable with. But obviously, coil spring is not as efficient as using the TADS, where you have a more rigid fixation. So this is a problem that we'll see. And I would tell you that today I am using clear aligners, and I find that those work really, really well, and we can manage those at the same time. So I think that has been a game changer in my practice, to be able to use those clear aligners for this sort of situation, where I would have doing 3D planning of those patients, and have more control over the process. Especially for these periodontal and implant cases, it's better to be in control of that process. So you see, we brought that canine anteriorly. Now we have just a single tooth defect. We super erupted those teeth, and you see, that's what we've created, a single tooth defect. So, this canine wasn't as efficient. I mean, he was using the coil spring, and I kept saying a little bit more, a little bit more. Finally, we decided to go ahead and do the bone augmentation, and he was going to continue with that. The other aspect is that we were using the SFOT, the surgically facilitated ortho. I had done corticotomies, didn't even use the orthodontist, didn't even use that. So it was really a shame. In any case, now we're going to use our technique of cortical, or the tenting screws. We harvested autogenous bone. We're using this little device, which is a rotary bone harvester. This is a very efficient device for harvesting autogenous bone, mixing it 50-50 with a xenograft. Then, in this case, we're using liquid PRF, and we're also chopping up some solid PRF and making sticky bone, and that's going to be used for the contour augmentation in this case. So we're installing those tenting screws. Those are the mod-fix tenting screws. We've done the membrane palatally, placed the sticky bone, and then on the roots of the teeth, we use some connective tissue graft just so that we have a little bit thicker tissue for the papillae. And then we layered on top of it PRF. And now we approximate a flap in a way to have primary coverage. And you see, this is before, this is where. So you see, with this process, we were able to move that canine from the canine position into the lateral incisor position. And the central, we super erupted that. So both of these were super erupted to improve their tissue. So you see, that's what we have. So remember, that canine had a lot of recession. Canine. Now it's in the lateral incisor. It doesn't have any recession anymore because of the forced eruption. And the central incisor also improved in the tissue contour because of that forced eruption. So by this kind of manipulation and interdisciplinary interaction, we were able to make our job easier. So now we're going to use some soft tissue grafting. This is a vascularized graft. This is called VI graft. So we're just basically using this kind of a pedicle soft tissue graft to give some more soft tissue bulk around the implant. You see, now we just have only a single tooth implant in the right central incisor, and we have a single implant in the canine position, and that's what we have. You see, that's the canine implant with the green healing abutment, and then we did a little bit more contour augmentation around that implant with some bone and soft tissue. So this is what we ended up with. You can see it took a long time to go through this process, but I could tell you these central lateral defects are very, very challenging. So by using the treatment planning modifications, we were able to make the outcome better. If you compare where she was before, you see that, remember the canine with severe attachment loss, the central with severe attachment loss. Now the central has much more normal contour. The canine is now a lateral incisor, and the position of the canine is a single implant. So all much better contour of these restorations, which would have been very challenging to place. Okay, so single implant. So as I mentioned to you, anytime you're doing bone augmentation, it's also important to consider soft tissue augmentation. Because what happens is that when we do, let's say in this case, we extracted 2 molars, we did GBR in that area, and after the GBR, you see, we end up with shortened vestibule. Because every time we do GBR, bone augmentation, we're pulling the flap together, and that moves the flap to the lingual or the palatal, so we lose vestibular depth. So you always have to plan, as a secondary step, some kind of a soft tissue augmentation or vestibuloplasty. And I'm going to show you 2 different ways of managing that, okay? So soft tissue augmentation is very important. You see that where the vestibule has ended up far, far palatally. So if you compare to where the teeth were, we lost significant amount of vestibular depth, and this is very common. So now we knew about the gingival phenotype. We now know about also the peri-implant phenotype. So I'll just show you how we manage gingival deficiencies, and that way we can learn some of those lessons and apply them for peri-implant augmentation. So now today, the current concept when we're treating periodontal recession defects and soft tissue deficiencies, we think about the gingival phenotype. The gingival phenotype consisting of gingival thickness and keratinized tissue. So we now know that the gingival thickness is the most important component in terms of the stability of the periodontium. So we know that stability of the gingival margin after treatment of gingival recession depends on the gingival thickness, and it can predict future recession. So for every 1 millimeter that we increase the thickness of the gingiva, we can reduce the possibility of recession by 0.71 millimeter. So we're taking these lessons from treatment of gingival recession, and now we can apply them to implant. So what do we know about the treatment of gingival recession? We know that we can use connective tissue graft, dermal matrix graft like alloderm, or collagen matrix, or just coronally advanced flap. And you can see in terms of keratinized tissue gain, connective tissue grafts give you the best result, but not the dermal matrix or collagen matrix don't give you much keratinized tissue. So, but in terms of gingival thickness, all of these materials are pretty much equal in terms of the ability to increase gingival thickness. So soft tissue graft substitutes are just as effective for gingival thickness gain. Okay? They're not going to give you keratinized tissue, but they are going to give you thickness gain. And that's the most important aspect in management of gingival recession. The same thing applies to implants. We're going to come to the implant, but I'll take you first of how we manage soft tissue deficiencies around teeth, and then I'll take you to the implant. Now, I'll show you a case of gingival recession defect, how we treat it, and we can see how we can apply these lessons to management of peri-implant deficiencies. This is a patient with severe gingival recessions on the canines especially, but also the other incisors have that. The teeth have a lot of wear. The patient doesn't like the aesthetics. There's caries on the canine. We're going to need to manage the patient's gingival recession, the caries, and on the right side, the tooth that had recession already was restored with the elongated crown that the patient doesn't like. So we're going to manage all of these. So you see, we're going to use a technique called Vista ABC. I will show the for the Vista ABC protocol of how to manage this recession defect. We're going to make a vestibular incision, okay? Vista stands for vestibular incision. We're going to make it in the midline. We use these instruments that are called ABC instruments because they divide the zones of dissection into 3 zones. The A zone is the vestibular zone above the mucogingival junction. We use the A instrument. The B zone is the zone of attached gingiva. We're going to use these instruments that are for B dissection. And the C zone are the papillae. So we have papilla elevators to address the C zone. So I'll show you how we go through these steps for our patient with gingival recession defect. We're going to first make our vestibular incision. We're going to use the A instruments for the A zone. These are more straight instruments that get into the vestibular zone above the mucogingival junction, and we make the A zone dissection. So this is the easiest area. All of the dissection is done subperiosteally. Means like you're doing a full thickness dissection, but from a vestibular side. The B zone is the attached gingiva. We use these instruments to go obliquely under attached gingiva. And then the C zone are the papillae, and we get underneath the papillae and elevate the papillae. So we go ABC from the vestibulum to the attached gingiva to the papillae. Now we're going to do odontoplasty because the area had the caries. We remove the caries with finishing burr and also reduce the prominence of the roots. So the same thing applies for teeth and implant. When you have prominent roots, you're going to have more recession. When you have prominent implants, you're going to have the peri-implant mucosal deficiencies because of the position of the teeth or implant. So we can correct the position of the teeth with some odontoplasty, and also on the natural tooth that had the elongated crown, we remove the margin of the crown that was extended above the CEJ. Next, we're going to place these sutures that are going to allow us to coronally position the gingiva. These are the steps of the suturing that will place to coronally advance the gingiva. And then we take these sutures and we bond them coronally with a little etching and composite to reposition the gingival margins coronally, and that allows to control the position of the gingival margin. So you can see that we are taking the sutures, we are repositioning the gingival margin coronally. We go inside the tunnel, push the tissues down to coronally advance the gingival margin. And you see we put mobile composite on the teeth, attach the position. I think the microphone goes in and out for whatever reason. But you see, the coronal advancement we're able to anchor those gingival margins coronally to be able to control the position. But remember, I explained to you about this protected space that we create with the bone. We're doing the same thing, creating a protected space under the tissues that we're going to create tissue thickness. So we're taking tuberosity. Tuberosity is harvested by first removing the surface epithelium. We're taking the tuberosity graft that we harvested. You see, too tiny. You don't need a large piece for these recession defects. Holding that gingival tissue right over the canine and going over the top and hooking that and being able to get the, you see that, attaching the tuberosity connective tissue right to the surface mucosa. But the main thing that we're using, this collagen matrix, this is called FibroGuide. We are hydrating it with liquid PRF. This is a collagen matrix that is partially cross-linked to make it last longer. These are excellent for increasing the tissue thickness around teeth and implant. So we're using that. You see, we're hydrated in liquid PRF. We are inserting it inside the tunnel. You see, it goes in very easily. Half of it on the right side, half of it on the left side. We work that tissue, that collagen matrix, the gingival margin, and that actually helps a lot to coronally position the gingival margin. We're using the sutures to anchor the gingival margin coronally, and you see that it helps to actually suture when you have that collagen matrix underneath there. This FibroGuide is about 6 millimeters in thickness, so it really gives you a very nice thickness gain. So we are etching those two teeth, we're rinsing, and then you see coronally position in the gingival margin. So you're going to be in charge of deciding exactly what should be the position of the gingival margin, coronally positioning all of that, and then putting PRF inside the tunnel. So that's the whole protocol of Vista ABC. We started at pre-op at 3 weeks, 4 months, and 12 months. You can see maturation. Remember how coronal, elongated the crown was on the right canine. That is now fully covered just with that vista with coronal advancement. So this is helpful to get the root coverage, harmonize the tissues, and what importantly, you see the thickness gain on both sides. So we are doing what we call phenotype modification therapy. We're changing the patient from a thin phenotype to a thick phenotype, and that phenotype is going to remain. So now, after 14 months, the patient comes back after having the prosthodontist restore the patient with new restorations. The patient was chief complaint that was unhappy with the aesthetics there. So you can see we're using the combination of the soft tissue grafting restorations to basically harmonize the gingival margin and make new restoration. So you can see that in terms of what we call phenotype modification, which is to increase the thickness, we're gaining about 1 millimeter of thickness, whether we're using the palate, whether we're using tuberosity, using a dermal allograft, or we're using the collagen matrix. Any of these materials, we're getting as much thickness gain as we need, which is about 1 millimeter. And the reason is that we're creating that protected space by this suturing technique, and that protected space give us enough thickness gain to be able to manage that. You see that we get about 5 of space, that if we fill it with the right skin tricks, we can increase the tissue thickness. This is Seiko Min, who's done this study to follow the patients to show that the thickness gain that is created with Vista stays very stable. You see he followed before and after. This is before, this is after, showing good amount of thickness gain that stays for at least 3 years follow-up. So now we have the possibility of having a stable thickness gain that was created around teeth. So now back to the implant. Does the same principle apply to implant? And the answer is yes. So we are now aware of the gingival phenotype. There's also a peri-implant phenotype. Remember, before we used to refer to these as the biotype. And the reason that these terms are changed is because phenotype is a physical characteristic. And phenotype is something that we can change. So we call that the gingival phenotype to refer to the gingival and what we do to increase the tissue thickness. And there's also a peri-implant phenotype, which basically refers to the physical characteristics of the peri-implant mucosa. And the concept is that we can modify the gingival phenotype, making the tissues more stable over time. And the same thing applies to peri-implant phenotype. Because we know that by peri-implant soft tissue modification has benefit not only for the tissues, but also to the bone. If you want the peri-implant bone to be stable, you have to, if your patient has a thin phenotype, you have to convert them to a thick phenotype. So that's the point, that every time we plan for these bone augmentation, we can't just focus on the bone. We have to pay attention to the soft tissues, because if we don't, we're going to get bone loss. I show you when I learned that lesson from my patient. This is one of my cases. Well, I didn't place those implants. Those implants were in the wrong position, so we removed those implants. So the implants were removed. We're planning on extracting the remaining teeth because of caries and attrition. So now we're going to place the implant using a guided approach, but at the time, I was only focused on the bone. We were only using guided implant placement. We did some of the areas that had some dehiscence. We did bone augmentation around it. No efforts to do any soft tissue management. And what happens after the restoration, you see that the implants were restored, but the patient has very, very thin peri-implant phenotype. You could see that. There's no tissue thickness, and as a result, there's some peri-implant recession, right? But also, there was bone loss. There was bone loss, and you could see that inflammation created even if the patient had great oral hygiene. This is the equivalent of basically biologic with invasion. When you have this thin phenotype and you have the implants with the thin phenotype, remodels because the body wants to create a thicker phenotype. If you can't build, Mother Nature will cause bone resorption, and that in essence. So our job is to intervene there and try to augment the tissue phenotype. So how do we do that? We're using what I described to you as a VISTA technique. That stands for vestibular incision, subperiosteal tunnel. We're placing, in this case, a connective tissue graft. So you see, we made a vestibular incision. Okay? Now, we create the tunneling, and we place a connective tissue graft. Now, the only thing is that when I describe the 3 zones for the maxilla, for correcting gingival recession defect, we use the A, B, C zone. The A zone is the vestibular zone, apical to the mucogingival junction. We can't do A zone dissection in the posterior mandible. Around these implants, if you do dissection in the A zone, which is in the vestibular side, you're going to run into the neurovascular bundle there, right? So in the posterior mandible, there's no dissection in the A zone. You don't do dissection in the vestibular side. You go right to the B zone, which is zone of attached tissue, and you would dissect only around the mucosal margin, and you feed this connective tissue graft in there, and that's going to create a nice thick tissue. So what we've done is phenotype modification therapy, which is our primary objective for treatment of gingival recession defects, but also around implants to change the phenotype of the patient from thin to thick. The same thing applies if you're doing immediate implant placement, if you're doing GBR, or you're doing implants. If you have a thin phenotype, it's very important that we modify it by some thickness gain, whether we use connective tissue graft, collagen matrix, or alloderm. We need to increase the tissue thickness. You see, we did the same thing to the left side. We did this VISTA, vestibular incision, tunneled posteriorly, placed the connective tissue graft. You see we have increased thickness, and we have much healthier tissues. So phenotype modification will lead to better health of the tissues. It would have been much better if I was thinking at a time when I placed the implants, I would also do the tissue grafting, but I was ignorant of that fact at the time. Now, it's important that we keep that as part of our protocol, that we pay attention to the mucosal phenotype, and if it's thin, we convert it to a thick phenotype. So you see, that's basically what we've done. You see, we started out with really very thin mucosal phenotype with no vestibular depth, right? No keratinized tissue. Still don't have any keratinized tissue. But whenever we do VISTA, we actually get deepening of the vestibule. You see that? The vestibule gets deeper. Even though the surface is not keratinized, because we place that connective tissue right under the periosteum, the surface is not changed, but the tissues adhere, so you get deepening of the vestibule and increased tissue thickness. And the same thing goes to the left side. You get deepening of the vestibule and tissue thickness, and you see much healthier tissue. So we need to learn these lessons, that rather than correcting the complication, we need to be proactive to manage them every time we have thin mucosa. Oh. Hello? It's okay? the microphone ran out of juice. As long as I don't run out of juice, it's okay, right? So these are the lessons we need to take in order to improve. Now, I showed you the VISTA technique as a way of managing the peri-implant vestibular depth. I will show you a newer technique. We call this 5 technique. 5 stands for fibrin immobilization vestibular extension. This is a very useful technique. We just published a paper that came out in April with Professor Ganati in University of Frankfurt and Dr. Pascal Valentini. So you remember the case that I showed you? A little too much echo. So where we lost vestibular depth, right? So we lost this vestibular depth as a result of GBR. This is the exposed tenting screws here, right? That's a tenting screw. We don't have any vestibular depth. So we could try to get some vestibular depth by moving our incision palatally when we place the implant. We did that just as a way of increasing the vestibular depth and moving that keratinized tissue from palate to buccal. But you see, when we did that, we still have shallow vestibule. We have keratinized tissue, but the patient still has this pull in their cheek that they have discomfort and complaining about the pull in the cheek. So if you want to deepen the vestibule, I will show you how we use this technique of 5 to increase vestibular depth without the need for other tissue grafting. So you see, we're doing our incision. We make the incision partially in keratinized tissue. So you see, there's going to be some keratinized tissue that's left at the crest, and the margin of the flap that we're making is also going to be moved apically. That flap has some keratinized tissue. We apically position that with partial dissection. Partial thickness dissection, we apically position that flap. So now we're installing the tenting screws. These are the MOSFET screws that I showed you. We installed them here. We left the periosteum in this area crestally, but it still has maybe some scar tissue from there as well. That's fine as long as it's not movable. So we installed in these tenting screws. What's the purpose? The purpose for these screws is to hold and stabilize these PRF membranes. We install these PRF membranes, and we just basically pass them through those tenting screws that we place. The purpose is that when we apically position the flap, we are going to have some exposed periosteum. We don't want to leave exposed periosteum because it will have delayed healing. So we cover that with PRF. We also stabilize that flap apically by puncturing that flap and using those tenting screws as a way of keeping the tissues apical. So you see, we are apically positioning the flap, and the area that is left bare, with bare periosteum, we cover it with this PRF. So if you think about it, you have on the crestal tissue, you have some keratinized tissue, apically position the flap, and the margin of that flap has a little bit of keratinized tissue. So we have keratinized tissue on the bottom, keratinized tissue on top. What do you think will fill in that space? Keratinized tissue, right? So let's see if it happens. And you see, this is 2 weeks later. You see, you get all keratinized tissue forming in there. You get lots of keratinized tissue with deeper vestibule without the need for autogenous tissue harvesting. So this is a very useful technique. You see pre-op, post-op, you get a huge amount of keratinized tissue because you don't have the same limitations as harvesting. And you see before, and this is after restoration, this after 2 years. You see, you get a nice wide band of attached tissue and deepening of the vestibule. And those are the steps. So you see, this is where it was before. That's the amount of gain that we see. So this is actually the data from the paper. You see that we apically position on the average about 10 millimeter. So we created a 10 millimeter space, like a centimeter, and by the time that it heals, after 3 months, up to 36 months, we gain about, on the average, about 4 millimeters of keratinized tissue that stays by 3 years. Now we've had some patients for 5 or 6 years, and that tissue is very stable over time. So this is, and actually when you look at the studies using free gingival graft, it's about the same amount of gain. So this is being gained without the need for free gingival graft harvesting. So this is a useful technique. So let's talk a little bit about posterior maxilla. Posterior maxilla is a challenging area because a lot of times you have multiple factors. You may have, in this case, you see severe horizontal deficiency. You see the crest of the ridge is toward the palate. The implants need to go here. You know, if you think about the ridge. And we have also vertical deficiency as well on both sides. So we're going to show you a step. Now the patient in this case did not want to be without teeth for any period of time. She was walking around with these failed implants. These are the short, I don't want to mention this brand that has pretty poor results, but they were failed and the dentist was just holding on to them for a while, but they destroyed the bone quite a bit. So what I did, you can actually see there's an implant in the third molar area. We placed one implant there, and we made a FBD, a bridge between that third molar implant and the anterior teeth so that the patient has fixed restoration. So you see, we're making our flap, and you see the implant there. Now this is that rotary harvester I was telling you about. You could see you can efficiently harvest quite a bit of bone from the same site. Because if you're harvesting from the same site, you see in this case we're using allograft. We're mixing autogenous bone with allograft. And then we use more harvesting from the posterior mandible as well. That way we're mixing more graft there, and then we're using liquid PRF to make our sticky bone. If you just mix liquid PRF with bone substitute, it makes like gravel. It doesn't really solidify. When you mix autogenous bone, you see how much of a nice sticky bone it makes for you. It gives a very nice texture, like a putty that you can work. So now we're installing the tenting screws, and you see how that sticky bone works like a putty. So this is really more of a PRF putty that we're creating, and that gives a nice texture, more stability. And then when we place the collagen membrane over that, we're using those same mod fix screws that I showed you earlier. You can basically use this as a way of membrane fixation as well as tenting. So then we use the suturing that I showed you already. We go from here with both horizontal and vertical deficiency to a much better width and height. And you see, we place our implants. This is the guide. And you see we had that tuberosity implant before that was serving as a way of rigid fixation. Again, I'm showing you different ways of modifying, so that way you have to provisional in ways that doesn't destroy the grafted bone. Always try to stay away from mucosa-supported restoration. So we placed a couple of implants. We had to also do simultaneous sinus augmentation to get some vertical height. And you see, we allowed it to heal. And now we're using the 5 technique to increase the vestibular depth later as we uncover those implants. So that's what we ended up. You see enough vestibular depth and the implant restored. Let me just skip that here. Going to the next case here. With this case, I want to also show you, this is again for restorative colleagues, it's very important to see. Patient with vertical deficiency, you see that there's super eruption of the mandibular teeth, so we proposed ortho to the patient. She refused. That would have been ideal to do ortho. And you see the premolars are rotated, and you see very, very narrow bone. It's kind of deceiving. A lot of times when you see a ridge like that, you see, wow, that's a good ridge. I can place implants with no problem. But when you look at this, it's like less than 2 millimeters of width of the bone. And that bone is monocortical, which is very difficult to augment. So we have both horizontal as well as vertical deficiency. So the vertical deficiency is A, B, or C. It's pretty much C, right? You see, the bone is really very flat. There's really no vertical walls. And in terms of concavity, there's some concavity, right? So this case is more favorable for horizontal augmentation than vertical. And it's subclass 3 because the ridge crest is very narrow. So this is a very, very poor case for vertical augmentation, right? Because it's class C, it's the worst one. There's really no vertical walls. And it has very narrow crest, so it's a very poor base. So I won't show you the surgery, but you see we place implants in the posterior with sinus augmentation. Anteriorly, we use the growth factor, the PDGF. You see, we use the VISTA technique for bone augmentation because we are trying to avoid that crestal incision. Instead, we make a vestibular incision, we use the tunneling, but you see, most people, when they think about vestibular tunneling, like the study that I showed you earlier, they made an incision and they used a syringe to inject particulate bone. That's not going to give you enough. Have you heard about the SMART technique, the bone grafting, right? It's a similar concept that they just make a vestibular incision and inject this graft material. And when you use that kind of a technique, it's just too simplified. You don't really have the way of stabilizing the graft. They're not using a membrane, they're not using tenting screws, any of that. But you see, when you're using VISTA, you have the ability to install these tenting screws. You can use a membrane. You can basically have everything that you do with a full thickness flap from the crest, except that there's no crestal incision. So the graft remains better contained. You see, we closed it. Now, how do you restore this patient Well, how do you send the patient home like this? What kind of restorations do you give the patient? Do you use a partial denture? What would you want to use? Yeah, you want to use an Essex appliance or a tooth-supported appliance. So we made the patient a tooth-supported appliance. This is an Essex. So that way you can see that we had to alter it quite a bit to make room for that massive amounts of graft to be placed, because you always have to overcorrect. But once the patient heals, that Essex is not so practical. The reason is that when you give the patient an Essex, they still have to remove it to eat, right? They can't eat with it. And if they're in a social situation, they're not going to be happy being without teeth. So the patients like something a little bit better. So this is another method of provisionalization for the graft. This is an overlay. This actually, I work with one of the local prosthodontists who created this. Basically, it has a metal framework and it has an acrylic superstructure. I think this was, I'm not sure if it was printed or if it's basically, this is probably a few years older, but there was probably not a printed, but it's an acrylic metal structure. You see, the framework is primarily on the palatal side to keep it rigid, but it requires no preparation of the teeth. It fits directly over all the teeth, so it's an overlay. So this was a very practical solution for a patient, because when you do this kind of augmentation, you have to wait about 9 months. And you can't keep the patient with an Essex for 9 months, and then you're going to place the implant. And so you want to have something more practical. So this, I thought, is a good solution. You see, we got a very good horizontal augmentation, okay? Because it was a concavity, it's favorable to horizontal augmentation. Not as much of a vertical augmentation as we hope because of the shape of the defect. So we're using guided surgery, but when you use guided surgery, I want you to see you still have lost the vestibular depth, just like all the other cases that I described to you. Anytime you use GBR, you're going to lose vestibular depth. So we placed the implant using a guided approach, but we still need to manage the tissues. We did a little bit of a pedicle graft, a VIP graft, to bulk up the tissues around these areas. But still, we need to do vestibular depth. At the time, this is the technique that was described by Ishtavan Urban, using the basically apical positioning and using the strip of, this is a mucograft, collagen matrix, and above that we use a free gingival graft. And I probably tell you that today, this is, I think, a lot of overkill. I think the 5 techniques that I showed you will be my go-to technique right now, because it's much simpler to implement. And you don't need the biomaterial. So here we put a dressing over that. These are the implants, and this is the restoration. So about how long, Dr. Kamal? We are ending at 4:30, right, Dr. Kamal? 4:15? Okay, so we have time. So we have just making decisions about to cover the more important. Okay, this is another consideration about posterior maxilla, which relate to treatment planning. This is very important, because when we're dealing with the posterior maxilla, we go back to that classification. We have the ABC. If you have the class A in the posterior maxilla, a lot of times when they see atrophic posterior maxilla, what do they think about? What's the first thing that most people think about how to manage it? Sinus lift, right? So if I did a sinus lift here, would that be a good idea? Dr. Al-Wazan, why not? Excellent, excellent. That's correct. So you can place sinus augmentation here apically, but then it's not going to correct the crestal deficiency. At the crest, you still have this contour defect. So if you have this contour defect, your implants are going to be in a ditch. You're going to have a big discrepancy between the implants and the adjacent teeth. So if you have an uneven contour and you place implants, you're going to have poor restoration, poor hygiene, and most likely have peri-implantitis. So this kind of A classification is not a good case for sinus. It's a better case for GBR because those vertical walls will help us with GBR. And then we place short implants. Or if you want to do longer implants, you could do sinus lift later. But first you have to correct the contour defect. But this is a good kind of a defect for contour augmentation. What about when you have a B class? When you have a B class, you have, this is very common. Most cases are B class because you have natural teeth in the anterior side that may have intact periodontium, but then the edentulous area will have a slope. So when you have a slope, you're going to have a B class. So if you try to do augmentation, GBR, you're going to have limited success, right? You would have limited success with GBR. So what's another solution? Another solution is maybe extract the posterior tooth that is periodontal defect. Now you're going to have a more even posterior side, but still you're going to have this kind of a crest that is deficient, right? You're going to have that slope. How do you manage that slope? What you can do, you could do sinus augmentation here. But if you do sinus augmentation, don't place an implant right next to this natural tooth. Because you have a tooth that has intact periodontium, and the ridge next to it is deficient. So if you place an implant right next to that tooth, you're going to have a huge discrepancy, and that's going to cause peri-implantitis. So one way to manage it is to manage it with cantilever pontic. That's a very good way, and this is a very common situation that you encounter. Probably the most common, because sinus is always a great way to do. I prefer to do sinus than GBR anytime we can, because it's more predictable, it's faster, and you can also do sinus augmentation and implant placement simultaneously. You can't do GBR and implant placement simultaneously if you have vertical defect. So that's a good way to manage Class B. Class C, what do you do there? You have two deficient teeth. Do you try to do GBR? No. Yeah, you could do sinus. Probably you're going to extract those teeth, right? And you could do sinus augmentation and place the implant. So these are the three situations, A, B, C, as it relates to the posterior maxilla. Again, it comes down to treatment planning that will be helpful for every member of the team. So you can see Class A is more suitable for GBR. As you come to Class C, it's more suitable for sinus augmentation. So those are the ways to manage. But there's one more protocol, right? The other option is to use a tilted implant. That is the fourth option. If you're going to be extracting those teeth, if those teeth are already being extracted, we would go with a graftless approach. We don't need to do bone augmentation at all. We would use the way of tilting the implant and placing the implants into native bone. So increasingly, for these kind of edentulous situations, we're using a no graft approach or graftless. So you see, these are the 4 choices that we have based on ABC classification. So this is one of the publications by Vahid Khoshgam, who demonstrated that when you have that discrepancy between an implant and an adjacent natural tooth, it will have a consequence. The consequence is more bone loss. So if you have more than 3 millimeters of discrepancy between an implant and an adjacent tooth, it's going to cause bone loss. So that is the situation we're describing very commonly. If you have that discrepancy, don't try to place an implant right next to the tooth, because you're going to have that discrepancy that's not solvable. So try to place a pontic there. So here's an example of a situation that I described. Is it A, B, or C? It's B, right? You have the most common situation where you have intact natural teeth, and then as it goes posteriorly, it slopes to a edentulous area. So this is a very common scenario. So how do you manage that? You have posterior deficiency. You're going to do GBR or sinus? Sinus. So that's what we did. We did sinus augmentation. We did a large amount of sinus augmentation. And then we took another CT scan and looking at that and say, oh my God, we still have deficiency. When we look at that, the ridge is over here, and we have that slope. How to manage that? You see, I wasn't thinking initially. You have to look at just not because at the time, you know, or automatically when you see deficiency in posterior maxilla, you think sinus. That's it. But then you would see, okay, there's more to it. You have to evaluate the crestal morphology. The crest is deficient. We need to do something about it. And I said, okay, we need to now do GBR. And the patient said, you're kidding me, right? It doesn't, you know, so this was my failure for planning, because I was just looking at one dimension of that deficiency, which was the atrophy and pneumatization of the sinus. So now, the way to correct it, which is actually ended up to be the best solution, is to use cantilever pontics. When you use cantilever pontics, you can use that posterior bone volume that you created with sinus augmentation and avoid managing anything in this region, which is the pontic area. So if you think about this ridge that is deficient and has a slope, you have the natural teeth that have intact periodontium. You don't want to place the implant on the slope. You want to place it on the plateau. So the plateau is usually at least one tooth away. So by leaving one space for the pontic and moving away one tooth, you're going to be able to place the implant on the plateau. And if there's some residual, you know, irregularities, you can actually do a little resection. You can actually flatten the ridge a little bit because you created enough volume, and that discrepancy in height is going to be less important if you have that pontic. The pontic can be just fine. So that's what we ended up doing in this case. You see, we used guided surgery, and you see in the pontic area, we did some contour augmentation, not for the purpose of the implant placement. The contour augmentation is just to create a more even contour of the ridge. So, but the key here was what we decided, which is to use a cantilever pontic and not place the implant on the slope. Okay? So you see the implant is on the plateau. So that discrepancy between the implant platform and the adjacent tooth, which is significant, now we created some distance in between that. It's going to not affect the health of that implant. Those implants are now 15 years out. So that is one way you think about these kind of contour deficiencies as a way of managing that. So now how do we manage fully edentulous patients? This is a patient who came in. She's in her 30s. She was from Philippines, and she was edentulated when she was, I think 20 years old. And she said, where she grew up, that was very common to edentulate the patient and not worry about, fixing those teeth. So she was fully edentulous in the maxilla and highly atrophic. So you have sinus pneumatization, right? Anteriorly, you have very narrow crest. So now we're thinking about augmentation for this patient. So how do we do that? In this case, we use the tenting screws for the anterior side, and we use the sinus augmentation in the posterior. So we did bilateral sinus augmentation in the posterior. Anteriorly, we're using the tenting screws to perform augmentation. We use large volume of bone. This is primarily mixture of autogenous and xenograft. Use a collagen membrane. Close the flap. So now we have sinus augmentation, and then we have ridge augmentation for the volume. The patient came with a denture. How do you send the patient home? Do you put the denture on top of it? Do you just put some soft liner there? If you do that, that's a recipe that your graft material will completely fail, right? So that graft material is going to turn into scar tissue, not into bone. So if you want to have some kind of provisionalization, you have to think something that is not mucosa supported. Now, you don't have any teeth to have tooth supported, but how do you do non-mucosa supported? This is a situation that we created. We place implants in the tuberosities, one each of tuberosities, and then we put one implant just posterior to the nasal foramen. And this is a good area of dense bone there that you can have an implant placed that you will be able to do immediate loading. And that's what we did for this patient. We did immediate loading using locators into the patient's denture. We eliminated all the flanges. So there's no flanges. The prosthesis is now implant supported, not tissue supported. And there's space there so that the only thing that I did, I loaded it up immediately, but I asked the patient not to wear it for a few days because we're going to have some edema. I just wanted to make sure the edema is under control before we seat it. Because this patient, they're going to have to be with it for at least 9 months, right? Because you're going to place an implant in this situation after 9 months. So you don't want the patient to have something of a denture, or you can't tell the patient not to wear anything, right? So after 9 months, we found that we didn't have enough bone in the anterior. Remember, the anterior was all monocortical bone. Monocortical bone means that you don't have any trabecular bone in between. You have solid bone. That means there's really no vascular supply. Though that kind of bone is really a poor base for grafting. So you have to, recognize that those kind of bones may need more than one round. And in this, we did vista for the patient. You see that? We did a vestibular incision, subperiosteal tunneling, and we used titanium mesh in there. Now, I told you that I don't, I see that the evidence for titanium mesh is a lot of complications. But in this case, we use it with vista, so there's no crestal incision, less chance of exposure. So we created the mesh, we put the mesh in there, and the space between the mesh and the bone, you see that part of it was not fully, there was some shrinkage there around those tenting screws, so we packed in lots of bone underneath there. And the bone in this case was spiked with growth factors. This is a recombinant human BMP2. And you see we packed the bone underneath. So we created a large volume of bone underneath using the vestibular tunneling. So then still the patient went home with that prosthesis that's supported with those three locator abutment. So now the patient is 1.5 years out, okay, because we waited 9 months for the first one, and then another 7-8 months for the second one before we went back in to place the implant. So you see before grafting, post grafting, and you see we're dealing with monocortical bone. This kind of a monocortical bone, and it's pretty flat, and you see the ridge was flat, so there's really no chance of vertical augmentation. It's a C class. So this is a C3, again, a poor ridge for vertical augmentation. So we were able to create enough volume to place the implant. So this is 1.5 years out that we're placing the implant. You see, we have a large volume of bone that was created. The worst part of titanium mesh is what? Removal, right? So that's why we call it the titanium mess, right? Because it's really hard to tease it away. It gets incorporated in the tissues. It's really the worst experience to try to remove it. We got a good volume of bone. You see that the bone volume is huge, okay? But now we have to dig out those tenting screws underneath the graft. How do we do that? We're using guided surgery. The guide is kind of complicated because we use part of sleeves for placing the implants, and we use these horizontal sleeves to actually retrieve those screws. See, once the guide is placed, this is a bone-supported guide. We actually have the sleeves leading to each screw so we can retrieve every screw. So now the implants have been placed. This is, I think, 2012 we did this. So at the time we were placing more implants. Today we probably don't feel the need to place so many implants. I probably would have placed no more than 6 implants there. But you see, those are the implants that we placed, and the patient is restored. There it is. So you see, we started out fully edentulous. It took almost 2 years to build this. So now we're looking at this protocol. Is this the best thing to do for the patient? Today, I would say, fully edentulous patient, I rarely do bone augmentation because most of these patients can be managed with graftless surgery. So let's see, when we're dealing with a patient like this, who we're going to edentulate because of the terminal dentition, I'm not thinking about sinus lift and GBR. In this kind of a case, we're thinking about using their native bone and placing the implants in positions where native bone exists. So here, we could see that you have sinus atrophy in the posterior, so we really don't have a chance to do implants in the posterior maxilla on the left, and the ridge is rather narrow. So rather than placing bone augmentation here to place the implants, we actually going to resect part of the crest, which is narrow, because the ridge is like a pyramid. The crest is narrow, and the base is wider. So if you resect the narrow part, you will have enough width to be able to place the implant. So you see, here are the teeth that are extracted. We're using guided surgery. We're placing the implants. And you see, we're doing resection. We are getting rid of the crest that is irregular, that is narrow, that is uneven. We're creating wide enough of a base by resecting that instead of grafting. So the benefit of this protocol is that we don't have to wait for 6 months, 9 months, year and a half to be able to place the implant. We could do that simultaneously. See, when you have edentulous patient or you're edentulating the patient, you can place all the implants at the same time. You have the ability that you don't have to take what the body gives you. You can create that harmony of the bone, you can resect the crest, and you come up with an even crest that you need, okay? And you can place the implants into native bone. So this is the immediate loading. This was actually one of the patients that my friend Lyndon Cooper and I were doing as the joint live surgery cases. So you see, after the healing, we're doing this kind of a prototype. I got some help from another good friend, Fernando Rojas Vizcaya, a prosthodontist in Spain, who helped me kind of with the prosthesis to make the prototype while the patient is having some ortho on the remaining teeth in the mandible. So you see, this is a much faster protocol. You don't have to wait for the bone to heal. You can extract, place the implants, and do immediate loading and send the patient home with fixed prosthesis. So there are many advantages to the protocol in terms of time and in terms of efficiency. So now we were able to go from there to here in much shorter period of time. So you see, we managed this posterior atrophy on the maxillary left with a tilted implant, right? We could avoid the sinus augmentation by riding along the anterior wall of the sinus. On the right side, we were able to pay an axially positioned straight implant, but short implant. So you don't have to, I mean, some people I see that they tilt the implants even if they have a lot of bone. So short implant is another alternative. If you have enough height for a 6 or 7 millimeter implant, that's another good option there as well. So you see, that's the case here. And when you look at this, the issue in that case is that when I look back at this case, you see, we did a resection. We could resect the anterior part, but posteriorly, because the sinus was here, we couldn't really resect. That's one of the limitations. So when we look at the final restoration, because we didn't do much resection in the posterior, so we ended up with shorter prosthetic space. So that is the limitation. One of the other reasons for the resection is to give enough prosthetic space. And if you don't have enough prosthetic space, what will happen is prosthetic failure. So we had several fractures in this area until the prosthodontist, in this case, put some titanium, or actually chrome cobalt framework inside to manage that. So you see this kind of I hate to call it an all-on-4, you know, this protocol of all-on-4, because it's not always 4, we place 6 implants, and we don't have to always tilt, we can use short implants. It's basically the protocol of using native bone and placing implants into existing native bone with alternatives to augmentation. So we're grafting less. So it's not graftless, we're grafting less. Sometimes we use some degree of grafting, but it's not the full protocol of GBR or sinus augmentation as we've been discussing. Now, the limitation of that is this. This patient is another lady who presented who had been edentulous for 30, 40 years. And this is all she has. She has 2 teeth, 3 teeth actually, and the ridge is completely atrophic. Atrophic sinus, atrophic crest. She has paper for bone, nothing there. So if you're trying to do, you know, implants into native bone, there is no native bone. So I know some colleagues will go for zygomatic implant. I'm not a big fan of zygomatic implants. I think those, I've seen enough of serious complications with pus gushing out of the areas and having 20, 30 millimeter pocket depth around them that, you know, the complications with those are not minor, they're major. So I try to avoid. But you can see very narrow crest, monocortical bone in the anterior. There's nothing that you can do with resection to come up with wide enough at the base. There is no base. So looking at this, you see nothing inferior to the sinus. Anteriorly also, the ridge crest is super, super thin. So the bone is very poor. It is what classification? A, B, or C? It's C, and it's C3, the worst bone that you can use for bone augmentation. So in these cases, I think still the sinus augmentation is our go-to. So we try to have the sinus augmentation really being the major area for, you know, predictable area of implant placement, and then we try not to place the implant anteriorly. Then again, we're going to think about how do we restore the patient after we graft it. We're going to graft the patient, and you can't do an Essex. You have those teeth in the back. You can't really do a denture with the locators that we did. So I consulted with some prosthodontic colleagues. They said it's impossible. We can't do anything. So I said, you know what? I'm going to try something myself. So this is what we ended up doing. I placed 2 implants in the anterior maxilla. This is along the palatal area, right near the nasopalatine foramen. There was just one patch of bone, not on the crest of the alveolar bone, but on the palate. So I placed 2 implants here. And then you see 2 implants in the anterior. Then what we did is to prep the teeth and created a prosthesis like this. I asked actually 2 prosthodontists. They said it's impossible, it will never work. So I just had to prove them wrong. So place this kind of a prosthesis, you see, prepped 1 tooth on each side with this kind of a prosthesis, and anteriorly it's supported by those 2 implants and posteriorly by those 2 teeth. Because I know that when we're managing a patient like this, it's going to be a long time. And you can't just have some kind of a rinky-dink, you know, interim prosthesis. you have to have something really predictable. So this is what we're dealing with. 2 implants anteriorly into a little patch of bone that she had, and posteriorly the teeth. So you see very much knife edge bone, monocortical, poor blood supply, and no vertical walls. So we rely on sinus augmentation posteriorly. You see that the sinus augmentation. Anteriorly, we're doing GBR. So GBR using sticky bone and then primary coverage. So I was able to manage sneaking 1 implant near that tooth because I could do it simultaneously with sinus augmentation, and the other ones were basically using this kind of a prosthesis that is combination of implant supported and tooth supported off of the tissue. So you see, that's a nice little prosthesis to last us a while. So we waited about 9 months. I was able to place the implants and doing one more round of GBR. Now, people are asking me, can you do GBR and vertical augmentation? I never do vertical augmentation because you can't really predict the position of the crest of the bone after GBR. But we did horizontal augmentation here to build up more bulk of bone around the implants that we placed. So doing one more round. So very often after GBR, when we place the implants, we do more contour augmentation just to give ourselves thicker peri-implant bone. And then layered with some PRF, and this is what we have. You see now we created a really large volume of bone, but you see those 2 implants are still very stable, and the prosthesis is very stable, and it allowed the tissues to heal without complication. If I had a tissue-supported appliance, I can guarantee you I would have graft exposure. If I use PTFE membrane, I can guarantee you I would have had many complications. So no complication in this case. You see, now when we expose the implants, we're doing one more thing, which is the 5 technique. Fibrin immobilization, vestibular extension. So you see, we are basically deepening the vestibule because especially when you're using these full arch prostheses, it's really useful to have a deepened vestibule for hygiene. So you see, when I place these implants, I try not to place anything anteriorly. These 2 implants are the temporary implants that we place palatally. So we're just keeping those just in case they're needed. Now I basically remove the multi-unit abutments from them to let them get submerged, but we keep them in. But then anteriorly, you see, we don't place implants here, maybe canine to canine, nothing there. The reason is that I want to have the leeway to bulk up that prosthesis to give the lip support, because if you place implants, they're going to be too far palatal and you're going to have hygiene problem there. So it's better to place the implants more posteriorly. So the final topic that I like to talk about is this business about complications, whether we manage them with bone or tissue grafting. So I talked about, this kind of a complication like this. The patient came in with these implants that were obviously in poor position, we don't call it recession. Around these implants, the proper term is peri-implant mucosal dehiscence. So, it's just a complicated term, but that's the proper term. But you can call it recession if you want. But you see that it's a really unaesthetic situation. You see the patient has a very high smile line, and you have these two, exposed implant components. How do we manage that? Now, do you manage these with bone augmentation or tissue augmentation? Most of the time, we try to manage these with tissue augmentation. These complications, tissue augmentation is better. You're going to think, why don't you just take those implants out? Well, these are the expandable implants. Expandable implants are not so simple to take out. The person who developed these expandable implants has a practice a few miles away from my office, so I see many of these kind of complications, and over the years, I've had to manage many of these kind of complications, really some quite catastrophic. Well, in any case, we decided not to take these implants out because of the defect that it will leave behind. So what we ended up doing was to remove the prosthesis and see implant in the central incisor is significantly outside of the prosthetic envelope. It's too far facial and too far apical. The lateral incisor is a little bit better. So the first thing we did was to remove the abutments and let the tissue heal. Just place the restoration that was the FPD that was off of these implants on the adjacent teeth. So that allowed the tissues to naturally heal in this area. And now we're going to allow the area to do some augmentation. We're going to do soft tissue augmentation using VISTA. So VISTA, we will do vestibular incision, subperiosteal tunnel, basically full thickness dissection using this approach. So you see we're doing the ABC zone. The A zone is in the vestibular zone above the mucogingival junction. The B zone is the attached gingiva. There's no papillae. But you see, what I want you to see with VISTA is not just an incision. It's a curtain. It's a window that you can open and you have access, but it's a vestibular window. And you see, when you view it that way, you can see that implant actually has bone around it. So this is not a bone deficiency. It's just that implant is in the wrong position. It's too far facial. So rather than taking it out, we're going to augment the tissue. We can't move the implant palatally. We're going to move the tissue facially. So we're going to harvest tuberosity. This is how we harvest tuberosity. We use a diamond burr. We de-epithelialize it in the patient. And in this case, I harvested the entire tuberosity, a very thick, big piece, and then place it, you see that, we place that inside the tunnel. We place it inside the tunnel, and that allowed the implants to be fully submerged. So you see, we created a massive amount of bulk in the areas that the implants were. So we created the tissue bulk. We basically brought the ridge out. Now, I know some colleagues like to perform contour augmentation with bone. I think we periodontists prefer to create contour augmentation with tissue because it's more predictable and you can basically create better shape, better contour, the eminence over the ridge that you want. So now you can see that now we can go ahead and expose. You see, we put the tuberosity graft in there to get the augmentation. Now we're able to sculpt the tissues and do the restoration, having performed this contour augmentation with soft tissues. So you see, it's a challenging situation, but you can use the combination of VISTA with tissue grafting to be able to manage that. So I think we've come to a point where we can wrap up and come to some summary conclusions about what we discussed today. We covered quite a bit of ground today in the 3.5 hours that we've had. So the important aspect is our decision making. The reason you're sitting here is not to improve your technical hand skills, it's really improve decision making, because that's going to make all of us better clinicians. But the decision making should be based on evidence. We don't make a decision because somebody told us. We look at the studies that have been done to look at the evidence-based approach, right? Then risk assessment, because by doing the risk assessment, by coming up with the classification, deciding on the defect morphology, we can decide which will be the best treatment option and what is the likelihood of achieving that success, so we can convey that to the patient, we can convey it to all members of the treatment team, so everybody has reasonable expectation. Then, when it comes to the actual protocol, flap management is one of the keys. We need to do flap management in order to be able to have better results. So understanding proper flap design is real important. Material selection, the kind of membranes we're going to select, the kind of biomaterials we're going to select, the kind of bone graft material we're going to select, biologics, all of these are very important. Graft stabilization, wound stabilization is the key. If you want to create real bone, if you want to create real tissue, it's all about creating a protected space and stabilizing the graft material that we want to use. Soft tissue augmentation is going to be an important part of the protocol. So we can't just do bone augmentation and then forget about it. Every time we do bone augmentation, we have to think about soft tissues, and that should be part of our treatment plan. Provisionalization is really important. Otherwise, we're going to destroy the bone that we worked so hard to create. So the provisionals should be non-mucosa supported. I showed you 4 or 5 different options, including the Essex, including the palatal locators, including the fixed implant and tooth supported, including an overlay. All of these are options that you can use to avoid the mucosa supported prosthesis. And just like anything else, anything that you take on, you have to not think that it's always going to work, because it's the Murphy's Law. Whatever could go wrong will go wrong, and there will be complications. Of course, you're going to select things that have lower complication rate, but you have to prepare yourself to manage those complications. With that, I want to invite you to a symposium that we have in the month of February. This is in our institute in Southern California, called the Leading Experts of Soft Tissue Regeneration. This will feature the keynote speaker is Professor Klaus Lang. Also, we have Professor Tony Scullion, Pat Allen, Leandro Chambron, and several other leading experts who will be there. Now, if you can't travel to LA, this is going to be in hybrid. So you can participate remotely. So if you're interested, you can scan that the QR code, and hopefully either you come and join us in person or remotely. With that, I have to say it's been an absolute honor for me to spend this afternoon with you. I want to thank you for staying here so late for so many hours, and I really appreciate the Kuwaiti Dental Association for inviting me so I can be able to be here and share this information with you. I really appreciate this opportunity. Thank you.
Thank you very much, Professor Zada, for the thorough presentation. It was our utmost pleasure having you for the past few hours. And I would like to remind you all that tomorrow, Dr. Zada will carry on a hands-on workshop on the 3D alveolar bone augmentation. It will take about 4 hours, right?
That's correct.
Still, registration is open. It is almost full. But still, if you are interested, you can go to the registration and try to register for it.
Do you mind if questions having
Absolutely.
any questions?
Feel free.
Audience, dear audience.
I'll be happy to entertain your question. Yes, sir. Our microphone is coming to you.
Thank you, Dr. Zada, for the presentation.
Thank
Do you ever make cortical perforations before you pack your graft?
Yes, this is one of the things that we don't have time to discuss today, but there is evidence that cortical perforations does improve the results in the short term, but after a while there's really no difference. So you could have a little bit better healing early on. So that's worth it to be able to do those intramural penetrations. Yeah, decortication.
Thank you very much.
Yes, sir.
Here.
Oh, yeah.
Thank you, Dr. Zada, for the very insightful and motivating lecture. Appreciate that. You mentioned using a native collagen membrane for your augmentations, and it's biologically very sound rationale. Can you give us some options in the market that are available besides Geislick's products?
Well, you have to look at the question regarding what kind of membranes to select. You have to look at which ones have had more evidence. Collagen membrane in general works better. There are several collagen membrane brands that work well. Technically, most of the time I use BioGuide because that's a native collagen and there's a lot of studies behind it, but there are many other brands that are available, so you have to look at what's available locally to use. I tend to use less of the cross-link membranes, but you know, if you manage those well, the cross-link membranes are fine. You just have to look at the tensile strength, the handling properties as well.
Thank you.
Yes, was there a question in the back also? No.
Any more? Right. On behalf of myself and on behalf of the KDA, I want to thank you for coming here, for accepting our invitation, and it's an honor to have you with us. Thank you so much. Small appreciation for you, sir.
Thank you. Ooh. Good catch.
Repeat the picture again. It's time for you to rest.
Thank you
Thanks
very
a lot.
much. I appreciate it.
Thank you for coming.
Thank you. Thank you.
Take care.
Thank you.
Now 10 to 15 minutes break until we have the next lecture with Dr. Mohammed Kamal.
ايه لحظة من ورا حاطنا انت